Good afternoon. My name is Ahmed. I'm a clinical virologist at the National Institute for Communicable Diseases in Johannesburg, and I was asked to give a talk this afternoon on the new strain of COVID-19 and how to keep children safe during the pandemic, with particular reference to the new research that is coming out on the variants, whether vitamins or supplementation should be provided to children, and the vaccine efficacy. So I'm going to start with describing what are COVID-19 variants. So COVID-19 is a coronavirus disease that was first reported from China at the end of 2019. It's caused by the Sars coronavirus 2 virus, which importantly is a RNA virus, that's a ribonucleic acid genome, as opposed to a DNA or deoxyribose nucleic acid virus. So new viral variants arise on account of genetic changes of the viral genome. And mutations can arise from substitutions or additions or deletions of the viral RNA genome. And that happens due to errors in viral replication. Now, RNA viruses are prone to making errors because they don't have a proofreading function during replication that DNA viruses or, for instance, human cells have. So they're very error prone when they do replicate, and you're expecting many mutations to arise. Most of those mutations that do occur from a viral replication cycle are silent, as in they don't actually cause protein changes in structure or function, or they actually result in viruses which are not viable and are unable to replicate. Occasionally, mutations do give rise to viruses which are able to survive and reproduce themselves, and those will result in a new population, which is referred to as a new lineage. Now, an accumulation of mutations in a lineage will then result in a new variant or a new clade. And new variants may differ from their parent clades or variants in their ability to replicate and spread. They may vary in their ability to cause severe disease, and importantly, they may also be more or less resistant to antibody neutralization. So the SARS coronavirus 2 genome is quite a large virus. It comprises about 30,000 bases or nucleotide bases that code for only 4 structural proteins and 8 non-structural proteins. And those structural proteins are referred to as the S protein or spike protein, the E protein or envelope protein, the M protein for membrane, and the N protein for nuclear capsid. The S protein is what gives the virus its actual shape and name, whereby it resembles a crown, so hence the virus is called a coronavirus. And that S protein is very important because it's the protein that actually is responsible for attaching to human cells. The receptor it attaches to is referred to as the ACE2 receptor, and then that virus gains access to the human cell and is able to replicate. Mutations causing protein shape changes in the S or spike protein have resulted in the virus binding more effectively to the human ACE2 receptor. And these mutations that have been described are referred to as the 501 mutations. So the first mutation was described in the UK, and that lineage, or rather that variant, is often referred to as the 501YV1. Variants were then discovered in South Africa, and that variant is referred to as the 501YV2, and then other variants have also been described in Brazil, and they're referred to as 501YV3. There are other terms that are also being given to these variants, so you will have heard the South African variant, or the Kent variant, or UK variant, or the Brazilian variant, but also they're also labeled in a different way, and the South African variant is also referred to as the B1351 variant. Now, the first variants that were described or discovered in South Africa were in October 2020 in Nelson Mandela Bay, and then genotyping occurred through a number of different provinces in the country, and it was found that for October 2020, about 12% of all the infections that were sequenced in South Africa were this new variant. And over the coming months, the new variant actually emerged as the dominant variant. And for January 2021, 94% of all the infections that have been sequenced in South Africa are actually the new 501v2 variant. What we've discovered is the new variant is likely to be more infectious, but not necessarily cause more severe disease. And the variant that we have in South Africa has additional mutations that have been found to reduce how well our antibodies bind to the virus. And this has had implications for vaccine efficacy, whereby some vaccines have been found to be less effective with preventing mild to moderate infection within South Africa. However, other vaccines, such as the Pfizer, Moderna, and Johnson & Johnson vaccines, have still been found to show promise with preventing infection, severe disease, and death with the new variant. So what are the implications of the 501v2 variant for South Africa? So diagnosis remains the same. Essentially, it is a PCR diagnosis. Diagnosis can also be done through an antigen test. Antibody tests, however, do not diagnose the disease, and importantly, antibody tests cannot be used as a marker of immunity. So diagnosis remains the same through PCR or antigen testing. In terms of routes of transmission with the new variant, they remain the same as well. So it's predominantly spread through droplets and close contact. And the preventative measures remain the same. So physical distancing, masking, and hand hygiene. With regards to nutritional supplements, in the absence of deficiency, they're not proven to be effective in either preventing or treating COVID-19. There's no difference that's been found in symptoms among people infected with the new variant. The risk factors for severe disease remain the same, and clinical management remains the same for those with severe disease, i.e. oxygen therapy, steroid use, and blood thinning medication to prevent clotting. Vaccine rollout. So there's data from South Africa to suggest that there's reduced effectiveness of certain vaccines to prevent mild or moderate disease in a young population. With that, the vaccine rollout program has had to adjust, whereby our primary objective in the South African vaccine program is to prevent severe disease and death. Essentially achieving population-level immunity within the near to short term remains aspirational. South Africa has adopted a phased approach to vaccination, whereby phase 1, where we have limited doses of vaccine, will be targeting healthcare workers, probably around 1 to 1.2 million of them within the coming months. Phase 2, where we are offering expanded access to vaccination of essential workers, those over 60 years of age, those with chronic diseases, and those who work or live in congregated settings. And then phase 3 will follow, whereby the rest of the population greater than 18 years of age are provided access to the vaccine. So the initial rollout will be using the Johnson & Johnson's vaccine, which is an adeno-26 vectored vaccine. It's a single-dose vaccine. It can be stored at fridge temperatures for approximately 3 months and remain stable. And with the context, or within the context of the new 501v2 variant, it's been found to be 57% effective from day 14 post-vaccination, with approximately 85% effectiveness against severe disease and a durability, we think, of approximately 8 months or longer. As it's not yet licensed, the current rollout, or the initial rollout, is under a phase 3B study, but it is expected that the vaccine will be licensed within the coming weeks. The first 80,000 doses arrived in South Africa on the 16th of February, and to date, more than 30,000 healthcare workers have been vaccinated, and it's expected that at least 300,000 doses will be available in South Africa by the end of March. And clinical trials for vaccine use in children are ongoing. So in terms of the future of SARS-CoV-2 variants, in summary, the 501YV2 SARS-CoV-2 variant harbors mutations associated with increased transmissibility as well as neutralizing antibody resistance. It's likely that there'll be new SARS-CoV-2 variants in the near future. In addition to mutations, viral recombination can also occur, and that's when viruses from 2 or more lineages infect the same cell and a new virus emerges. We don't know whether future mutations and variants will make the virus more infectious or cause more severe disease. However, what's very clear is the predominant variants that will be described going forward will be the most infectious variants, just because it's a matter of survival of the fittest. And reassuringly, mutations within other circulating coronaviruses, of which there are 4, do not necessarily cause more severe disease. So we're hopeful that just because the virus will mutate, it doesn't necessarily mean that more individuals will succumb to severe disease. And hopefully the vaccines can also be re-engineered to match the dominant variants and improve vaccine effectiveness in a timely manner. Very importantly, the basic principles of COVID-19 prevention, diagnosis, and treatment will likely remain the same despite the emergence of the new variants. And I'd like to recommend that you go on to the National Institute of Communicable Disease website for further information and additional resources. That's at www.nicd.ac.za, and there are specific resources for children as well. Thank you very much.